Insufficiency, POI. Millie's recording the session for us. She's on hand from the training hub today. So if you've got any technical issues or anything, please reach out to her in the chat. You'll be emailed a copy of the recording as well as the slides and a resource sheet later on. So don't feel like you've got to take any notes or anything as you go. There'll also be a feedback form. Please do fill it in if you can. Even just a couple of comments are really useful, and do go into the planning for future events. We are looking at some more women's health education events over the next few months. So if you do have any particular topics that you'd like covered, please let me know in the chat or on the feedback form later on. And I'm really pleased to be joined today by Dr. Harriet Delap, GP and BMS specialist. Harriet's going to be answering your questions in the chat, and we'll pick up and expand on different things that we look at in the presentation today. So please do post any questions you've got. If there's anything that's unclear and you want a bit more detail, please feel free to pop anything in the chat and we'll pick up on that regularly throughout the presentation. Great, so let's make a start. So really hoping that today's session is going to be a practical one, that it's going to be useful for you working in primary care. The advice given is all based on national guidance, and there'll be lots of links kind of shared to that guidance later on. Firstly, just a note on language that although I'll be referring to women today, all of the information applies to anyone experiencing menopause, whether or not they identify as a woman themselves. So this is what we're going to look at. Why POI is important, what it is, why it happens, how can we recognise it in primary care and make a diagnosis, and what sort of management should we be supporting people with. And we'll think about our roles in primary care as well as the secondary care, more specialist management. I'll share lots of resources for you, lots of signposting for your patients, and we'll also look at some QI ideas, how you could look at supporting people in your practice with some QI topics. So what is POI? Well, it's a clinical syndrome that's defined by the loss of ovarian activity before the age of 40. And it's characterised by amenorrhea, low estrogen levels, and high gonadotrophin, so a high FSH level. Language is really important. So there have been lots of different terms used over the years. Premature ovarian failure was often used, and you may well find if you look at your computer system that many people with POI perhaps will be coded as having premature ovarian failure. The word failure is really quite emotive, and POI is more accurate and much more acceptable to patients. So there's a definite move towards using POI rather than premature ovarian failure. And the cutoff age of 40 used in this definition is essentially based on this being more than 2 standard deviations below the age of natural menopause. So it's important to remember that the natural age of menopause does vary across different ethnic groups across the world. So in the UK, the typical age is 51, but in Southeast Asia, for example, it's 46. And we know from the SWAN study that Black women are 3 times as likely to experience POI. So we can see real marked differences in different populations. And these are the prevalence figures that have traditionally been quoted: 1 in 100 under the age of 40, 1 in 1,000 under the age of 30, and 1 in 10,000 under the age of 20. But actually more recent data suggests the global prevalence is up to 3.5%, so perhaps much more common than we've traditionally thought. As to why POI is important, well, it's quite common. So if we think about the prevalence of common presentations in primary care, so celiac disease around 1%, AF around 2%, hypothyroidism around 5%. So with a prevalence of between perhaps 1 and 3%, this is something that we're going to see. This is something that we're going to come across. And where we can recognise POI and support women with appropriate management, we can make a huge difference to their quality of life today, but also to their long-term health outcomes. So we really can make a key difference here with some fairly basic management. Where POI is not recognised and not treated, it's associated with a reduced life expectancy, largely due to the cardiovascular effects. And we also see really significant impacts on fertility, on sexual function, on mental health, heart health, bone health, and brain health. I'll explore these areas in turn just over the next few slides. So in terms of fertility and pregnancy, a patient survey back in 2011 of patients with POI rated this as the top concern for patients. There is a possibility of spontaneous conception around 5 to 10%. And if conception does occur, these pregnancies don't seem to be at any higher risk. Unfortunately, medication to induce ovulation hasn't been helpful for this group, but egg donation is an established option in terms of fertility. And of course, some people won't want to conceive. And so it's important to remember for us that HRT is not contraceptive. So we need to take into account the priorities of the person in front of us. Second on that list of concerns from patients in the survey was responsiveness to sex. And we know that sexual well-being and sexual function are often affected. So it's really important for us to remember this and really proactively inquire and support women with this area. And again, we may need to think quite holistically, not just looking at our HRT, but sometimes thinking about counselling and things as well. In terms of mental health, a diagnosis of POI can be absolutely devastating for some, particularly for those who still wish to conceive. As we've said, language matters, premature ovarian failure being very emotive and might suggest the woman herself is partly to blame for her experience. And POI can be a really isolating time. The experience of going through menopause at 25 is quite different to going through menopause at 52. And so POI specific information, specific resources are really useful. And I'll signpost you to lots of good resources later on. As for the impact on heart health, well, we've got observational data showing that people with POI are at an increased risk of cardiovascular disease, including coronary heart disease and heart failure. And HRT until the natural age of menopause is likely to lower these long-term risks of cardiovascular disease. Of course, it's really important we remember lifestyle too. We don't want to forget talking about smoking and exercise and things as well. Bone health is impacted too, POI being associated with reduced bone mineral density and an increased risk of fracture later in life. So again, our management around HRT and lifestyle being really supportive for optimizing bone health for the long term. And in women with POI, bisphosphonates are not first-line treatment and really should only be considered after discussion with an osteoporosis specialist, particularly if that woman may ideally desire a pregnancy. And there's more and more attention at the moment in terms of the role of estrogen with cognition. Women with POI should be advised that taking HRT until the natural age of menopause, so around 51, is likely to improve their cognitive function and lower their risk of dementia. So we've got a pattern here, haven't we? HRT until the natural age of menopause, and don't forget lifestyle. And we'll explore the kind of the management a little bit more later on. So Harriet, anything about the impacts of POI or anything from the chat so far to pick up on?
Nothing from the chat so far. No questions in there. Does anybody want to ask any questions at all? No hands going up. Yeah, I mean, I would just say the impact can be enormous, can't it? And there's so many things that need to be explored with people with POI. And although we're meant to refer these patients onwards, and I'm sure you'll discuss that, but as a GP, you do take a really important role in the sort of holistic and overall care for these women, because you're in a really good position to do that.
Yeah. Yeah, absolutely. I couldn't agree more. And especially for that long-term kind of path as well, that, yeah, absolutely. Great, thank you. Well, let's have a little think about the why next. We'll have a little look at the etiology, and then we'll come back to the real kind of practical management about how we can recognise and support women. So it's always been said that the majority of cases are idiopathic, that we don't really know why. Actually, it's thought now that probably the genetic factors are more important than we've recognised, probably represent a larger group than historically we've thought, particularly for those who may present with primary amenorrhea compared to those with secondary amenorrhea. The majority of the genetic factors are chromosomal abnormalities associated with the X chromosome. And so genetic testing is particularly important, especially if there's a family history. Around 5% of people may have an autoimmune cause, and the prevalence of autoimmune conditions is more common in women with POI. So particularly with the adrenal gland, so the adrenal being affected by sort of 60 to 80% of women, and the thyroid being the second most common other organ affected. POI can result after medical interventions, so chemotherapy, radiotherapy, surgery. And of course, with the improvements in things like the prognosis after childhood cancer, we're seeing an increase in the number of women with iatrogenic POI. And then there can be other causes too. There are some recent studies suggesting that women with HIV may be at increased risk. And also if there's been any sort of surgical treatments in that pelvic area that might affect the blood supply to the ovaries. So a number of possible factors. In terms of how we're going to recognise it, well, the same as how we recognise menopause in any situation, we're looking at a change in cycle and potentially menopause symptoms. So the change in cycle in terms of POI, we're thinking about amenorrhea or oligomenorrhea. That usually is secondary. So usually somebody will have been having periods that then have stopped, but can be primary where periods haven't started at all. And although amenorrhea is not officially diagnosed until periods have stopped for 6 months, there's sort of general agreement that after 3 to 4 months, it's very reasonable to be looking at starting some investigations. And of course, there are a number of different reasons why periods may stop. And again, we'll come on to looking at the tests that can help us to think about POI, but also about those other conditions as well. Menopause symptoms are quite common in POI, but the symptoms can really vary and they can be intermittent. So the vasomotor symptoms, the hot flushes and the night sweats are the most symptoms that are most commonly reported. And then also insomnia and joint pain, changes in mood and concentration, low energy and low libido. And the genitourinary symptoms are really common. So 40 to 50% of women will be experiencing some of these genitourinary symptoms. And then more than 10% of women won't have any symptoms at all, which can be quite a challenge in terms of potentially women coming forward to talk about their experience and for us being able to make that diagnosis and then support that woman with management. So there are some very real challenges here for us in terms of finding those people who are living with POI. So in our history, it's useful to kind of think about the menstrual pattern. We know that about 50% of women with POI will have had a change in bleeding pattern leading up to when their periods stopped. It's useful to think about whether they've been using any recent contraception, so obviously particularly things like the depot injection, where it can take quite some time for cycles to re-establish after stopping. Exploring any medical factors, so any known autoimmune conditions, any iatrogenic factors that you can see on their past history list. And is there a history in their family of POI? We know the incidence of spontaneous POI in first-degree relatives is quoted as being around 10 to 15%. So a family history is really useful to ask about. And then again, remembering our other causes. So thinking about asking around symptoms that may lead you towards perhaps an eating disorder, perhaps polycystic ovarian syndrome. So thinking more broadly too. Sensitively asking about fertility plans obviously is really important in terms of you understanding the impact for the woman of a potential diagnosis. And then inquiring about menopause symptoms. And I think, again, for us, remembering that a woman in her 20s may not have much awareness of what menopause symptoms might be. So consideration to using something like a symptom checker where she can see all of the possible symptoms, because she may not know potentially what to expect. So for us in primary care, the main times we're going to be thinking about POI will be in secondary amenorrhea and potentially where there are menopausal symptoms in somebody under the age of 40. These symptoms can sometimes come on in the pill-free week of the combined pill. I can think of a couple of patients over the years who've come to me and said, oh, well, I'm getting night sweats and hot flushes in that week off the pill. So there can be a variety of different presentations. And the timely diagnosis is really key if we can make it, but it is really challenging sometimes. And there can be quite a significant delay. So more than 50% of people will have seen over 3 clinicians before the diagnosis is made. And 25% of the time, the diagnosis can take more than 5 years. And I think there's lots of factors that, that come behind that. This is a chart from the CKS guidance around investigating secondary amenorrhea. We'll look at some of the tests and things in a moment, but I've put this in really to kind of highlight, to remember the other conditions that can also lead to secondary amenorrhea. So again, remembering other conditions too. And this chart's potentially quite a useful one to remember in terms of thinking about your results of your tests and what those results may point you towards. So as you can see with POI, our estrogen levels are usually low, and then we've got those raised gonadotrophins, the FSH and the LH. So this is an example of a case that I think really demonstrates some of the challenges around making that diagnosis. So Sophie's 34, recently attended for cervical screening, and her nurse really noticed that it was much more painful for her than normal. And so asked Sophie a few questions, and actually she has been having a lot of trouble with vaginal dryness, and sex has been really painful. She hadn't really thought too much of that, so she thought it was all down to the birth of her second child 11 months ago. She breastfed for 6 months, and actually she's been really pleased that her periods haven't come back yet, because they were always really heavy and painful. Of course, she's feeling tired. All mums feel tired, don't they, at this stage? And yes, she has had some night sweats, but you know they can be a feature of breastfeeding, and they've come and gone. So Sophie could well have POI, but you can see how easily it is just to kind of normalise this collection of different symptoms, both from Sophie's perspective and from a clinician's perspective too. So it can be quite tricky sometimes to kind of tease out what's happening and recognise when it's really important then to think about moving on to some investigations. Any thoughts, Harriet?
Yeah, nothing in the chat. So do raise your hands if you've got anything you'd like to ask now. So Rosemary, you've just asked, when you say don't give bisphosphonates, I assume this is for risk reduction rather than when osteoporosis is confirmed on DEXA. I think I would still go with HRT even if osteoporosis is confirmed on a DEXA scan. Certainly in women with POI. There's really good evidence that it protects the bones really well, and it doesn't have all of the horrible side effects and risks that bisphosphonates have. So no, HRT is, Sam, would you agree, the primary treatment for osteoporosis in POI?
Yeah, absolutely. That's right. It's going to be, really good treatment and give lots of other benefits too. And it's the first line treatment in POI for osteoporosis. Yeah.
I've had a few people ask what the optimum dose of estrogen is for bone protection. I don't think there's good guidance to support us, but my understanding is that 50 microgram patch would give good bone protection, and that's enough. And then further dose increases would be relating to symptoms rather than anything else. Would that be your understanding, Sam?
Yeah, I agree. I think the very low level HRT, we're not confident enough necessarily. So the sort of, the 25 patch, the 1 pump of estrogel probably isn't enough to know for sure you've got that good bone protection. But I'd agree.
And that goes for,
up.
And that goes for heart and brain health as well. That sort of mid dose is enough for that, for all of that.
Yeah.
I've got quite a few. I've got not quite a few, but maybe 2 or 3 patients who have had significant delays in their diagnosis of POI, and the challenges can be huge. One issue is FSH that fluctuates a lot, and they've been raised in the past and then come back as much more normal, but the woman's still getting symptoms, but the clinician thinks, so it can't be that because the FSH has returned to normal. But if you look at it over time, actually, it's persistently above where it should be. So, and it is a shame when those patients don't have an opportunity to be given HRT in a timely fashion, because the risks that you can prevent, the things you can reduce risk of, are so significant.
Yeah, absolutely. We'll come on to looking at the bloods in just a moment. Yeah.
Ruth's just commented that it can be hard to diagnose, particularly in the case that you presented, Sam. And I think that's probably one thing, and the reason Ruth points out is that estrogen and prolactin and hormone levels are all over the place anyway. And I think that's one of the issues, that it often does take several visits to the clinician. I think you often can't absolutely diagnose it the first time it comes in, and you might be doing symptom diaries like Sam suggested, repeating blood tests down the line, and really making sure that that woman doesn't go away and that they know how important it is to come back, whatever their situation is at the time, because you need to look at things over a period, over a period of time. So just ensuring good follow-up and not losing those patients.
Yeah, absolutely. And I think it's not a criticism of us in primary care that we can't make the doses at the first visit. It's often just not possible. It is seeing what happens over time, and there's lots of different factors that we need to explore. So it's not straightforward.
No.
Let's have a little look then at some of the blood tests. So in terms of thinking about making a diagnosis, obviously the guidelines for POI talk about how to diagnose POI, but obviously from a primary care perspective, we're going to be faced with somebody that we're seeing who probably has a change in their cycle, their periods may have stopped, and we don't know what the cause is. So we need to start with a pregnancy test. Let's not forget the basics. Often women obviously will have done those at home already, but starting with that. And then really our next test is the FSH. As Harriet has already said, we usually need at least 2 levels, and the levels that we get can vary quite significantly. So you may have one level that's very raised, and then a subsequent cycle, she may ovulate and the level may be normal. And then the next cycle, it could be really raised again. So we can get this fluctuating pattern, which can feel then really confusing. Just as a reminder, with the FSH level, we can't rely on that if somebody is on the combined pill. We can use it with other hormonal methods of contraception, but just as a reminder. In terms of the interpretation of the results, so the guidelines all give slightly different levels in terms of where they would look at being the point of diagnosing POI. But any of our levels above, a level of 20 or more is going to be really quite unusual for somebody, for example, in their 20s. So looking at the absolute value, but also looking at repeating it in the context of the person in front of you with their clinical picture, with their cycle and with their symptoms. The LH, the estradiol, the prolactin are not necessarily essential to diagnose POI, but may well be helpful for you in terms of thinking about your differential. So helping you to think about whether the prolactin's high, whether this is looking more like PCOS, whether it's looking like they've got an eating disorder and their hormone levels are really suppressed. So other blood tests can be useful to think about assessing the cause of the symptoms, even if they're not essential in diagnosing POI itself. And I've put in brackets here on the slide, assessing ovarian reserve. So these tests aren't done as standard, but they're sometimes done by secondary care if it is unclear, if it's not clear-cut exactly what the cause of those symptoms are, then the ovarian reserve is sometimes assessed on scan and also through AMH testing in cases where it's not kind of clear-cut, but not for us to be worrying about, but just so that you know if you see that on a letter as to why those tests may have been done. The other tests that are advised think about the cause of the POI and also think about the kind of the long-term health. So thinking about the cause, we're mainly looking at that genetic group and that autoimmune group from where we looked at the etiology. This is a chart that comes from our remedy guideline about POI in terms of the tests that are recommended to be done in primary care before referral. So we've got our thyroid and our adrenal testing there, looking at those autoimmune causes. The chromosome analysis is usually done by secondary care, so we don't need to worry about doing that ourselves before referral. And then the other testing, mainly thinking about the long-term health. So an assessment around HbA1c, an assessment around kind of heart health. POI isn't in Q risk as a risk factor, even though we know it's a very big risk factor. Q risk at the moment doesn't include that in terms of assessing somebody's cardiovascular risk. So just worth bearing that in mind, that it will underestimate somebody's cardiovascular risk. Hopefully their risk does return to their expected risk if they are well supported with HRT. But if they weren't taking it, then the Q risk would really underestimate that risk. And then an assessment of their bone health, I think a DEXA scan at the baseline, at the point of diagnosis, is really useful. Again, the FRAX score is only validated from age 40, so we can't use the FRAX in terms of assessing risk before age 40. The Q fracture risk score does go from 33. But again, POI would be a very definite risk factor for osteoporosis, and we'd be really wanting to get an assessment of their baseline bone health, particularly if the diagnosis, if there's been a bit of a delay perhaps in terms of presentation or making that diagnosis. Harry, I know you tried to organise a DEXA recently for somebody with POI, didn't you? Did you manage to get that sorted in the end?
No. And actually, frustratingly, she is a woman who probably has had a bit of a delay in her diagnosis as well. But I did challenge it with radiology, and I got a resounding, this isn't going to change this woman's management at this moment in time. So I think that the DEXA scanning department is under huge pressure. And although it would be really useful and reassuring to know the woman's baseline bone density, she's on her HRT at the right dose, so
good. Yeah.
couldn't really fight anymore. So yeah, there is a challenge in that scenario at the moment. Yeah.
Putting guidelines into practice is sometimes tricky.
Yes. Yeah. She's not been seen in secondary care yet, so maybe they'll have more luck.
Yeah.
But there are no other questions in the chat at the moment.
Okay, thank you. So in terms of thinking about management, it is recommended that all those with POI are referred through for specialist support. As we've said already, I think the role of primary care is still really key alongside that. We see the two things as working together. POI specific patient support groups are really important. Daisy Network is a national organisation who do a lot of work about raising the profile of POI. Mothering in the Menopause is a local support group that also runs online, that's run by a mum who's also a health visitor. She's experienced POI herself. My Life on Pause is a book written by a surgeon about her own experience as a medic with POI. And again, I'll link out to these resources to you later on so that you can signpost patients to them. But again, thinking about specific resources for POI is really useful. If you're 25, you're not going to identify with reading around the generic support that's out there. So we talked about lifestyle. So we know that the cornerstone of the management is HRT, which we'll come to at the moment, but really supporting people to optimize their sleep, their nutrition. When we're thinking about their bone health, thinking about vitamin D and strength training, smoking and alcohol. So these kind of key cornerstones in terms of lifestyle being really useful for us to talk about at the point of diagnosis and also in the annual reviews. And then coming on to HRT. So we're looking at using HRT until the natural age of menopause, at least. So ideally until age 51. And we do find that women often need quite high doses for that good symptom control. So it's not at all unusual to need to go up to that 100 dose of the patch, potentially the 4 pumps of the gel, sometimes higher again. So high doses are often needed to get the same sort of symptom control that a lower dose may provide to somebody at the natural age of menopause. We talked last time in the HRT talk about blood testing, looking at sort of levels of estrogen on HRT, and we talked around how there's no set level that we aim for, but if we are doing levels for women with POI, again, we may well need a higher level. We may well be looking at levels of 600, 700, 800, compared to perhaps to 400 or so at the age of natural menopause. So we're aiming to get a physiological kind of level of replacement that's going to give that heart protection, that bone protection for the long term. If somebody does ideally want to conceive, then sequential HRT is recommended. So we have that regular proliferation of the endometrium. I would definitely offer the local estrogen treatments alongside the systemic ones. We know women with POI often have really severe urogenital symptoms. And so the addition of that local HRT alongside the systemic HRT is really valuable. And testosterone can also be of particular benefit for this group of women, although we do have less evidence in terms of the long-term use of testosterone. And we tend to favour HRT over the combined pill, but the combined pill is an option, and that sometimes it's much more acceptable to some younger women. They may feel much happier taking the pill, the same as their friends take, compared to using HRT. And of course, if they also have a requirement for contraception, it can feel like it may be the best choice for the person in front of you. HRT does seem to give slightly better protection in terms of bone health and heart health, but again, it's individualizing it, working out what's acceptable to the person in front of you. And if she's happy to take the combined pill, but wouldn't be happy to take HRT, then it's definitely better than not having anything at all. So And there are different pills now that do contain estradiol rather than ethinyl estradiol, which again is the favoured type of estrogen, if we can. Clara is the pill with estradiol that is amber on the formulary, so potentially maybe started in secondary care for us to be able to continue for women with POI in terms of supporting their symptoms and also giving contraception too. So kind of really trying to look at what's going to work well for that person, thinking about how they feel about using their HRT. They may be looking at using it for 20, 30 years, you know, depending on their age. So they need to be happy with what they're doing. They need to understand how to apply it, and they need to know it's safe. And not only that it's safe sort of day to day, but also that using it for this amount of time doesn't increase their breast cancer risk. So they may have heard around using HRT for longer lengths of time, increasing breast cancer risk, but we can be very reassuring for this group that the data is really good. So really trying to help them to understand the benefits. And I think, again, that's where our role in primary care of a sort of annual checkup can again be really valuable, coming back to looking at how is the HRT or combined pill working for them? Are they taking it as prescribed? You know, is it supporting their symptoms? And just having that opportunity just to kind of keep educating, keep talking about why we're using it, what the benefits are for the long term. Alongside that, again, thinking about lifestyle, thinking about the heart health and the bone health. Is there anything else that we can do in terms of sort of supporting that? And there's some recommendation around some regular checks, again, thinking particularly about the bloods, looking at the thyroid and adrenal, potentially every sort of 3 to 5 years or so. So this could lend itself quite well to a little template and annual kind of review project in primary care potentially. And, you know, again, remembering back to those top concerns for patients: fertility, responsiveness to sex, long-term use of HRT was the third concern. People worry about taking it for a long time. So this can be our opportunity just to kind of talk about those worries and help people understand that it gives really significant benefits.
Sorry, I've got my mic off now. So a couple of questions or comments. One from Jenny, who just has written that she had a lady not on contraception with amenorrhea in her mid-30s with FSH and LH that came back as naught. And was just puzzled by that. I think you're right to have requested repeat. Jenny, she's obviously not got PO. Well, she's probably not got POI.
No.
pretty. And it's. I mean, I don't know what other symptoms she had and things, but yeah, suggests something going on. Hypothalamic, pituitary type sort of maybe just whether she had any secondary sex characteristics or anything. It's a bit suspicious of something more significant, I would just think. Lisa just asked, did you have anything else about that FSH of LH of naught, Sam?
Yeah, I'd agree. I mean, I've never seen them of naught. I've seen them very low in the sort of HPA causes, but never zero. So yes, I would repeat them as well. But then yes, to be really looking at the different causes.
Lisa was just asking whether we're able to prescribe Zoeli. If it's not on the formulary, then in theory we're not supposed to prescribe, but yeah.
Yeah, I don't think Zoli is on the formulary yet. No, I don't know if an application's in for it or not. I'm not sure. But yeah, Clara is as an amber for POI if there's a need for contraception. Yeah.
Yeah. No other questions on the chat at the moment.
Great, thank you. So a few QI ideas in terms of just looking at the data in your practice and kind of thinking around projects if you're feeling super keen. I've got a couple of GP colleagues who also work in research who are happy to support clinicians in setting up projects around QI work for looking at POI. So if you're interested in that, let me know and I can forward your details on. But just starting with simply looking, how many people have you got coded as POI? You know, remembering that the prevalence is perhaps 1 to 3%. How many are out there that we don't know about? And what codes have been used? You know, has POI been coded or has premature ovarian failure been coded? And so if somebody's looking at their notes, looking at a letter, are they going to see that word failure? So that can be just something to think about. Of the people that you do know about, how many have had an assessment of things like their heart health and their bone health? How many are using good dose HRT or the combined pill to be supportive not only of their symptoms but of their long-term health? Have local estrogen been offered? As a team, are you good at sort of proactively offering local estrogen and talking about sexual function? It can be one of the areas that's hardest, I think, for patients to bring up with us. So it can be down to us just to take that responsibility, just to remember to ask. And sometimes it's the key area that somebody really wants to talk about. And how are they doing psychologically? Are they in need of any extra support in terms of how this has affected their sense of self, their hopes and dreams for the long term, particularly around fertility? So just really remembering the kind of huge range of different issues that can potentially throw up for people. Again, a sort of templated type of use on the computer sometimes is quite useful for this sort of thing, isn't it? When there's lots of different areas to remember, just having a few prompts there, because this isn't going to be something you're doing every day. So using the computer to help can be really, really valuable. Just to let you know about a couple of other things, there is a research study that's recruiting at the moment, including in Bristol. So the POISE study is looking at comparing HRT and the combined pill in terms of clinical outcomes and also symptoms reported by patients. So if you do refer somebody in, they may well be invited to join the study. And there's also a registry that's been set up, an international registry, but based here in the UK, which has the aim really of kind of better understanding POI, of sort of pulling together different treatment regimes and trying to improve overall patient care. So again, many of the secondary care consultants will refer people into the POI registry, so that essentially a database in terms of us knowing who's out there experiencing POI. There's lots of different guidelines out there, some very detailed ones that are useful as references, things, and some that are a bit more primary care focused. So again, I'll send you a link to lots of different resources. I think the ones from the Primary Care Women's Health Foundation tend to be very user-friendly, really looking at things from the primary care point of view. The other bigger documents are great as a resource, in terms of looking if you have a particular question. So useful to have a range. And I've mentioned some of these already, but again, the POI specific resources I think are really key. So Daisy Network are great. There's this book by Dr. Hannah Short, Complete Guide to POI. Back in 2020, the World Menopause Day campaign was about PMI. So they've produced a leaflet that's available in lots of different languages, which is quite useful. And they have some posters as well, which can be used in terms of raising awareness that POI exists and that it can happen. And I've mentioned the mothering and the menopause support group. So again, some potentially quite unique challenges in terms of facing POI and parenting small children. That's come to the end of the presentation, Harriet. Are there any more questions from the chat there at all?
No more questions in the chat. Does anyone want to ask anything? Put their hand up. Nothing coming.
So I think the main messages really are that it's common, that it's good for us just to, keep it there, keep remembering it. If we're seeing people with potential symptoms, if we're seeing people whose periods have stopped or paused or are just changing and a bit erratic, I'd have quite a low threshold for thinking about doing an FSH. And even if there's one level that's a little bit raised, I take that seriously.
I think that's a really, really important message, that one, actually,
yeah.
Sam. I think those are the ones that get missed and don't, and especially ones that have come into the surgery from different practices and things like that. And you look back historically and just don't ignore a single raised FSH.
Yeah, there's so many consequences, and it's something that's so easy to treat potentially if we think about it. But that's the key bit. Yeah. Thank you. Well, thanks for joining today. Please do get back to us if you've got any feedback. The form will come through this afternoon. If there are any more topics that you'd like to look at some updates on over the next few months, then please shout. But yeah, thanks very much.
Thanks, everyone. Thanks for coming.